Hello, everybody. My name is David Esselman. I'm the Chief Strategy Officer at BrainFutures with my partner today, Victor Cabral. We're going to talk about psychedelic-assisted therapy, sort of an overview of his promising intervention. BrainFutures is a 501c3 based out of the Mental Health Association of Maryland, focused on promising interventions that are likely to come to the market or in the market right now and are not adopted at an adequate rate. And so as a nonprofit, we really focus on how to make that possible. So we've looked at everything from neurofeedback and TMS to youth executive function technologies, and now we're focused on psychedelic-assisted therapy. So I'll let Victor introduce himself and we'll get started.
Hi, everyone. My name is Victor Cabral, and I'm the Director of Policy and Regulatory Affairs at Fluence Training, which is a training and education company based out of New York that's focused on training clinicians and healthcare professionals in psychedelic-assisted therapy in preparation for the FDA approval of these medicines. In addition to my role at Fluence, I'm also a licensed social worker, and I have training in MDMA-assisted therapy and ketamine-assisted therapy. Really glad to be here today and to tell you more about psychedelic-assisted therapy with David.
Great. Well, thank you, everybody. Just a little bit of psychedelic-assisted therapy. I mean, I think many people have seen that this has been something that's come up a lot in social media and mass media. If we go to the next slide, I think probably it all started to kind of hit the deluge about 5 years ago with Michael Pollan's book on how to change your mind. You know, Michael Pollan's obviously a best-selling author on a series of different books, mostly around food and gardening. And the way that his life sort of transcended, he decided to do a little exploration around psychedelics in general. And this book really about 5 years ago started, I think what has been a pretty substantial spike in interest in what these compounds do. Preceding that, and the book covers this, at Johns Hopkins about 15 years ago, there was a restart of research into psychedelic-assisted therapy in particular. And so I think the 15 years of Roland Griffiths, an incredible researcher that's had a couple of different careers on the research side, really got this going. And then with Michael Pollan kind of making it more available, you since have seen this happen, references to this happen in everything from Gwyneth Paltrow's Goop commercials and Goop show to Joe Rogan to a lot of congressmen, frankly, that work a lot with the special operations community, et cetera. And so I think it's now at the time where there's a lot of research happening, there's a lot of interest happening, and we're really excited today to kind of walk through how we feel like is the best approach based on what we've learned and make you aware of what's going to be possible in what we anticipate in 2024, 2025 of MDMA-assisted therapy being on the market. So if we go to the next slide, when we're talking about psychedelic-assisted therapy, we are talking about the psychedelic, the compound itself or the drug, in addition to therapy. And so we want to be really clear that as we're going through this process, this is really thinking through how do we make this work within a therapeutic modality? If you look at the clinical trials and the protocols that are being used at the various research centers around the country, and frankly, that you've seen in the practicing of this work in other cultures around the world for, frankly, thousands of years, there is typically both a community and a therapeutic aspect to it. So we just want to make clear that what we're talking about here is the psychedelic plus the therapy. Next slide. So, I think there's oftentimes questions about what are psychedelics, and the reality is it's a class of drugs with a lot of different misnomers about it. I just want to let everyone know a little bit about the chemistry. We're not going to get too deep into it, but essentially at the top of this slide here, you see what a serotonin molecule looks like, and below it you see similar structures of what is a variety of different psychedelic compounds. The ones on the left, mostly looking at DMT, LSD, which is the third one, psilocin and psilocybin, which is the active ingredient in what's known as magic mushrooms, as well as mescaline on the right side, are considered the classic naturally occurring psychedelic compounds. There's also a class called tactogens. That's just kind of a new reference, but it's really about people make references to being heart opening or more socially active when under the influence of these compounds. And the most common one that we're going to talk about at some length today is MDMA. And then finally on the far right, there's actually ketamine. This This is a compound that's not considered a classic, and frankly, not even a non-classic psychedelic by many. But the reality is that it's been used in a therapeutic context off-label for decades now, commonly around depression, alcohol use disorder, and in a variety of other sort of novel ways that are still being explored. So to give you a little sense about the research today, there's actually nearly 500 trials happening on clinicaltrials.gov that is looking at various aspects of how psychedelics can be used to treat a indication. Most of those are involving MDMA, psilocybin, and DMT, which is the active compound in things like various cactuses in the Southwest, et cetera. And it's usually looked at in the idea of how to support or treat depression, anxiety, and substance use disorders. So if you look on clinicaltrials.gov and see what's actively out there, it'll typically be within that constellation of indications and with these specific compounds primarily. So make one note here, the scale on the left is a little bit different. The one on the bottom is up to 500, the one on the top is up to 250. This is actually a scale of research that's been happening at major institutions since the 1950s. And we see, particularly on the top with psilocybin, at the bottom with LSD, which is actually the most researched compound that we have. You can see there's a lot of activity leading up until the 60s. And then there was a spike, particularly on the LSD scale on the bottom, in around 1968 to 1972, but with the Controlled Substances Act passing under President Nixon in 1970, there was actually a massive shutdown of research. And to give you a sense of this, this was literally happening at dozens of institutions across the world. And within a year, not just did the US shut down, but as did most of the research around the world. The one exception actually carried on, which is why there's a tail until 1975 at the Spring Grove facility in Maryland. It's tied to Johns Hopkins and the University of Maryland. And at that hospital, they were doing LSD research until 1975. And then we hit this trough for about 25 years, frankly, where we essentially relied on chemists in Switzerland and researchers primarily in Zurich, in addition to a few nonprofits in the West, mostly led by the Hefter Research Institute, to try to keep the research going and allow for there to be more learnings as everyone anticipated at some point there would be some reinterest in this. Because the reality is, up until President Nixon decided that this class of drugs was frankly dangerous, and if you recall, he referred to Timothy Leary, who had previously been at Harvard and been a researcher in this space, the most dangerous man in America. And when he made that essentially one-man decision to push the Controlled Substances Act, it had shut down 20 years of promising research. And if you go back to that time, the reality is that by research protocols, there's still a lot that could have been approved upon about how they did that research. But the overwhelming evidence that this was supposed to be an incredibly excited class of drugs to service a variety of different indications. And so fortunately, about 15 years ago, you saw Johns Hopkins pick this back up. And since then, NYU and UCLA were also fairly actively involved. Yale, particularly with the National Center for PTSD, was as well. And now we've had a fair explosion in interest among researchers. In no better way can we show this than with a map. This is the universities, almost all of which are R1, so the highest level of research universities in the world, doing research right now around psychedelic-assisted therapy. And I have to give some credit. There's a lot going on in Canada, in Europe, in Australia, and other places. Israel, for instance, is doing a lot as well. But there's no place that's had the proliferation of research interest as there has been in the US. And if you see everywhere from the East Coast, Ivy League institutions like Harvard and Yale and Penn are active in this space. In the South, we've got the University of Alabama, Birmingham, and Emory and Duke. There's really interesting applied research studies happening right now with the University of Texas and some partners in Mexico. And then, 5 of the University of California system universities, and soon probably 7, are going to create a consortium around research for this. And it's everything from basic science to the neuroscience that's related to psychedelic-assisted therapy to what the actual components and practices are that are going to make this the most effective. So to give you a sense about why we're talking about this right now in summer of 2023 is we anticipate that the first new FDA-approved psychedelic-assisted therapy protocol will be approved by the FDA sometime next year. Different estimates between the second and fourth quarter of next year, but that's for MDMA-assisted therapy. So we talked a little bit about how that's in the tactogen class of psychedelics. And so as we are right now here in this first half of 2023, the only compound that's comparable that's available today is ketamine. And there are a lot of practitioners. Frankly, there's a lot that we're learning about both how to do this well and how not to do this well with the way that it's being used off-label. But it's used right now for a variety of different indications, including the ones that we've talked about primarily, which is PTSD, depression, and anxiety. When MDMA-assisted therapy comes up next year, so the FDA will approve, and then within 90 days, the DEA will reschedule, by regulation that's required, and then MDMA-assisted therapy for PTSD specifically will be approved by the U.S. government. There are actually, if we go back to 2017 and 2018, the FDA granted breakthrough therapy status for MDMA in 2017. And MAPS.org is the organization, MAPS Public Benefit Corporation is the drug development corporation that's driving that process. And then in 2018, psilocybin, both from Compass Pathways, which is based in the UK, and USONA Institute in Wisconsin, also got breakthrough therapy status for psilocybin assisted therapy, specifically focused on treatment-resistant depression and major depressive disorder. All three of those compounds are in phase 3 right now, which is the third, and there's actually a fourth safety phase, but this is the third efficacy phase of the FDA process. And so we anticipate MDMA-assisted therapy in 24, and then psilocybin will probably follow in 26. So I'll turn this over to Victor in a second, but I just want to say why this is important. The reality is at any time there's a new class of drugs that come onto the market, and particularly when there is a therapy component that is going to need to be incorporated into it to be the most effective, there's obviously a lag time in terms of approval. And so we think it's really important to sort of make you aware of this now, because if you have any interest, this is the time to start to really read more, learn about what the right pathway is for you to be trained in this work. And we'll talk at the end about what that looks like, and really start to anticipate what's happening. Because when there's a bunch of components of this approach that are new to how we approach, medical services in general and behavioral services. And so this therapy plus drug combination is something that not only do we have to work through a lot of regulatory and rules around that, we have to educate providers and payers about how to do this a little bit differently so that practitioners can be reimbursed for it. And the sooner we can get more licensed folks to take this up, get involved, understand the nuances of it, and then frankly help us figure out the right way to bring this to market most effectively is important. So we're really excited to have this conversation with you today. And with that, I'll turn it over to Victor.
So why all the interest in psychedelic-assisted therapy? The reality is that in the middle of a mental health crisis, and we have been for quite a number of years, especially after COVID, and also there hasn't been any significant breakthrough in mental health drugs since SSRIs, and so clinicians populations that were, have been struggling with PTSD and with other severe mental health illnesses. I was getting to a point in my own work where hoping for something to come that would show results that would really reignite my passion for mental health and feeling like I was helping the folks that I was providing services to. And so what we're seeing with psychedelic-assisted therapy is significant results. We saw an NYU study where 83% of the participants saw a reduction in heavy drinking after just two doses of psilocybin, combined with psychotherapy, of course. And we've also seen in the MAP study, which is focused on treatment-resistant post-traumatic stress disorder, after protocol participants of the participants no longer met criteria for PTSD. And they gain those benefits and continue to get better for up to a year afterwards. And so, and just to give you an idea of how effective these medicines are, the participants on average had struggled with post-traumatic stress disorder from anywhere from 12 to 17 years on average, and weren't able to find an effective treatment. And so through their MDMA assisted therapy, they were able, after just 3 dosing sessions over the course of several months, were able to no longer meet criteria for PTSD. So the results are unprecedented. It's really exciting, especially for those folks that are wanting to see their clients get better and wanting new treatments and new modalities to do their work. So another area where psychedelic-assisted therapy shows some promise is in the treatment of racial trauma. And racial trauma refers to the psychological and emotional stress that people experience when they have witnessed or have been directly subjected to racism at the interpersonal, institutional, and or structural level. And so when we look at the symptoms of racial trauma, we see that they're very similar to symptoms of post-traumatic stress disorder, depression. So they include persistent negative beliefs about self or others or the world, negative mood, shame, guilt, blame, and hypervigilance. So research shows that experiencing racism has devastating effects on both our mental health and our physical health. And over the course of a lifespan, can actually shorten people's lifespan and impact our health in a number of ways. So in 2020, Dr. Monica Williams led a pilot study that explored the efficacy of psychedelic-assisted therapy to treat racial trauma. And the results showed that the participants experienced improvement in depression, in anxiety, and in PTSD symptoms, and were able to sustain those improvements after after going through the therapy. And these are folks who had experienced suffering from depression, anxiety, and PTSD, and had also been victims of or witnessed racial discrimination. So it's a very promising therapy that we symptoms and some of the things that impact historically marginalized communities. And that's another aspect of this work and of this therapy that I think is really exciting to bring to clients and bring to communities. So what are these drugs safe, right? Are these substances safe? That's usually one of the first questions we get from folks. There's a lot of stigma and a lot of history around many of these substances. And so rightfully so, there's some concern about how are these substances going to impact people, and what are the dangers or the risks or the safety. And so what you're seeing here is a ranking of different substances ranked from most or least safe to most safe. And as you can see, you have alcohol at the top of that list. You have heroin below that. Somewhere about a third of the way down, you have tobacco. And then in the middle there, you have ketamine. And if you go further down, you have ecstasy and mushrooms or psilocybin all the way at the bottom of that list. And I do want to clarify that there is a difference between MDMA and ecstasy. Ecstasy is a street drug that can in which the active ingredient is MDMA, but there can also be other adulterants that are in that drug, versus MDMA, which is the isolated compound or substance that's active in ecstasy. And so when we think about that, there's a good chance that MDMA, if we're looking at it in its purest form, coming out of a lab, is probably safer than ecstasy on this list if you would separate the two. But as you can see, psilocybin is the safest on this list in terms of uh, uh, just being safe for folks. And you have alcohol and tobacco at the top of that list, which are legal. But when you look at the scheduling of these different substances, you have substances like heroin that are scheduled in the same schedule as they're Schedule 1, and they're scheduled in the same scheduling as like mushrooms, as MDMA, as marijuana. And so based on what we're looking at here, we can see that there's a need for us to really start to look at the science around these medicines and to really start to rethink some of our preconceived notions about their safety, about their efficacy, because a Schedule 1 drug is the classification means that these drugs have no medical benefit, and that they have a high abuse for potential. They have a high potential for abuse. And so, as you can see here, psilocybin is one of the safest compounds on this list. So I'll pass it back to David now to talk more about the different elements of psychedelic-assisted therapy and really walk you through what the different sessions look like and what you can expect. David?
Great. Thank you, Victor. So a couple of years ago, BrainFutures had some interest, mostly because we are based in Maryland, from Johns Hopkins, the University of Maryland, to start to look again at psychedelic-assisted therapy and think about how it could become a therapeutic offering within the market. And so we did a series of papers. There's 3 of them. It's available on our website at brainfutures.org. The first of which looked at the research across 7 compounds over time. So we looked at the ones that we are talking about today, like ketamine and MDMA and psilocybin, but also DMT, LSD, ayahuasca, et cetera. And so that first paper is available on our website and really looks at probably the best clinical evidence to date. That was released about a year ago, so everything up until then is included. And then our second paper was, how do we actually allow this to proliferate within the existing behavioral and medical context? And so that was something that I think we've been working on a lot with our various partners in this space. But the third paper, which came out towards the end of last year, is really what we're going to talk about now, which is we went out to the experts at a variety of different clinical research centers, as well as folks that have been operating internationally over the last 50 years since Prohibition happened within the US, about what are the elements of psychedelic-assisted therapy that make it work. How is this different than just experiencing the compound on your own? And what is it about this therapeutic alliance and the experience that really makes it work? And we'll see here on this slide is essentially the summary of it. The big circle around it is that safety and establishment of set and setting, which I'll get into a second, are paramount to whether or not there's efficacy in the experience. And anytime you look at a protocol, it's usually something similar to this, where someone will be screened to potentially participate in a clinical trial, for instance. If they qualify, then they will be prepared for that experience. Then that's typically a few sessions, usually a week or spread several weeks apart. Then there's a medication session itself, which is the dosing session with the actual compound. And sometimes there'll be 3 medication sessions. So for instance, the MAPS MDMA-assisted therapy protocol for PTSD has 3 medication sessions, and they're typically spaced about a month apart. And then there's integration that happens both between those medication sessions, but also afterwards to really make meaning of what the experience is. And we'll go through each component of it now so you get a better sense of what this actually looks like. So just to remind you, we went and talked to Johns Hopkins and UCLA and experts in the ketamine space, indigenous practitioners from around the world, folks that have been operating in Mexico and other places where it's still legal. And we saw very consistent ideas about how this works best. And so we're really excited to share each of these components now. So screening and assessment is an obvious one. When we're talking about servicing for an indication, it's both important to understand, does this person actually have this indication, and is this the right modality to treat it with? And so oftentimes in the clinical trials, but I think we'll also see this in practice, people will be essentially screened out, looking at psychological and physiological conditions. So psychological safety is incredibly important for this to be efficacious, but it's really also important to just understand where people's mindset is at this point to make sure this is the right modality for them. So the one thing that's important about medical history is there's a number of things that you want to look for. You want to understand what compounds people are on right now. You want to understand why they got onto those compounds, particularly with SSRIs, because there's oftentimes a clinical history that you're going to want to be aware of. Additionally, you should also be aware of the potentiality for repressed memories to come up or things that might be triggering during an experience, and just understand that those are part of the overall perspective that you're going to want to bring into the process, because it is very common for repressed memories to come up during the medication session. And so just being aware of it and making sure that through preparation, you can start to both develop the therapeutic alliance, but additionally just ask the right questions so you can be as prepared as possible if that does happen, is crucial. Finally, contraindications with prescriptions and actually asking about illicit drug use is important, because at the end of the day, SSRIs in particular can have a deadening effect on the same receptors in the brain that these compounds act on. And so it's important to just understand what's going on chemically with these individuals. And we'll talk about it a little bit later too, but oftentimes tapering off of SSRIs is really important. And then we'll see common assessments like you experienced with the MRDRS and CAPS-5 for PTSD. These are going to be used, I suspect in a clinical setting as well. And hopefully we'll aggregate data over time as well, because we're seeing a lot of promise in the research protocols, but we really will benefit by also using these same common assessments when we get to real world data when this hits the market. So assuming somebody is screened and qualifies for this service, then what will typically happen is preparation. And I think ideally we would like to see this woven into people's existing therapeutic relationships. So if you're a therapist and this is part of one modality that you've added on, maybe this is you're in cognitive behavioral therapy with someone for some time, you realize this is the right next step for somebody, or they ask you about it and it feels appropriate. Once that's decided, then you go through these preparation sessions. In the research protocols, what will typically happen is you will be assigned a therapist, you will have a preparation session. They'll be spaced anywhere from a week to a month apart. And during these sessions, it's really important to, again, establish the therapeutic alliance, understand psychological safety at the same time, because at the, Robin Carhart Harris, who is most famously at Imperial College London and recently moved to the University of California, San Francisco, is one of the major researchers in the space. He is starting to see in a study that he's that is not quite out yet, that people's psychological safety going into this process is actually correlated to how effective it is. And so it's really important to make sure that people are in feel safe about this or in the right mindset about it. It's also really incredibly important to educate the patient about what this looks like and why this is important and what the promise is, and also the fact that it does not work for everybody, and just making sure that the patient is as comfortable with what they're going to be experiencing. Because again, if they have never experienced a non-ordinary state of consciousness, it's really incredibly important for them to have as much information. So while they're in that experience, they can sort of navigate it in a way that's still healthy, and also to understand that you as the therapist gave them that, that those safety protocols, that safe information, which ends up helping a lot when events could essentially, could become adverse. So, the other thing is going to be really important here, because in a non-ordinary state of consciousness, you cannot give consent, is to really educate and get informed consent from the patient themselves, because you want to make sure that you're really clear about everything that's going to happen and how you're going to act as a therapist. Because again, there's things that might come up that you're not aware of, particularly past traumas, where there could be something that is triggering. That you just have to try to uncover as much as possible, and then know what you do in the event that one of those things happens. So informed consent is incredibly important, as is establishing safety measures. There's a very small percentage of people, much lower than we typically see in other classes of drugs that we're talking about, but there can be adverse events, and there will be. And so what do you do to elevate that if it becomes a medical emergency? And how do you talk about that in advance so that somebody is aware that if they need to go to an emergency room, et cetera, this is what's going to happen. So it's not a surprise during the medication session itself. And then it's just walking through what that day will look like. So you'll typically do that in your last preparation session, just so that the client can get time to process what they're going to be experiencing and really be ready for it. And then finally, because of that last several weeks, typically, you'll want to taper people off any medication that might end up acting with any of the brain receptors for the compound that you've chosen for therapy. All right, next slide. So we talked a little bit about set and setting. This was actually coined back in the middle of the last century. There are a series of studies right now happening at Emory, at McGill University in Canada and others, on Johns Hopkins, for instance, around how music plays into this, about what actually is important around the set, kind of the mindset of the individual when they go into the medication session, and the setting, the social and the physical environment that they're going to be experiencing in that process. You see in a slide on the right, the Johns Hopkins has led this research for quite some time. The Aquilina Cancer Center is close by, and they recently started the Bill Richards Center for Healing. And they designed essentially a bottom-up therapeutic environment based on the best that we know in set and setting right now. You can see it's a relaxing environment. You'll see a therapy room in a future slide. They also are thinking about how the way people enter the building to make sure it doesn't feel clinical and how important that is. They're thinking about how music ends up playing an effect both as they enter the building, but while they're on the experience. And so it's really critically important to think about what is the patient's mindset, what is the environment that they're walking into, and then also the social. What people are they going to interact with? In the research protocols right now, it's 2 therapists to 1 patient. We'll see what the FDA decides on whether or not they'll relax that or how they'll have it change. But from the time someone steps into the facility all the way through the process, what is their experience going to be with individuals, and how do we make sure that all of it is as supportive of a positive therapeutic experience as possible? And over the next few years, I think we'll see a lot of research on these specific components, and we'll learn a lot more. But at this point, there's enough out there where I think we can start to do this relatively well in short order. So the medication session itself, this is actually the room at the Aquilina Cancer Center, where you see somebody on a couch with eye shades. Typically the day of a medication session, they'll show up. There's, depending on the compound, there'll be different instructions around whether or not to eat prior, how you should think about the day before to make sure that you're in the right mindset. It's not particularly helpful for somebody from a mindset perspective to have a really busy day, come in on a flight, for instance, at the night before. So that is something that's really important, and really preparing people to come into this fully. And it's also really important to make sure that people are ready. So checking in with them is wildly important. And in this, unlike most aspects of therapy, this is actually a relatively passive day for the therapist. There's a lot of questions and a lot of inquiry in the preparation. There will be a lot in the integration. But during this day, the role is to really allow the patient to direct their own experience. There's a lot of talk and various books about the inner healer and people being able to heal themselves, and neuroplasticity really being supported by this type of experience. And so that day is really about setting back and allowing for people to go through their own process. So oftentimes the therapist will be providing support and reassurance, but generally refrains from influencing the experience. So just to keep in mind, MDMA-assisted therapy session or a psilocybin can be anywhere from 6 to 8 hours long. So this is something that is also, it's going to take some preparation for the therapist to be ready for, because that's a long time to sit, particularly when there are long periods of time when seemingly not much is happening. And so just want to prepare people for what that looks like. But also, one thing that I think has been helpful in some of the studies, and I think from anecdotally, people will say this as well, is that therapists have been known not to take notes about what the experience is or things of that nature, but to really scribe what they're hearing or seeing the patient actually go through. And that'll be helpful to potentially bring up during the integration process, which we'll talk about next. So integration is the series of events that happen, after the medication session. And the reality is, there's a lot of exuberance around the compound and experiencing the compound and being in a non-ordinary state of consciousness and what that looks like. The reality is, from a therapeutic standpoint, I think general feelings are, and I think research will probably prove this over time, that most of the therapeutic benefits come after the medication session. So the neuroplasticity that is sort of enhanced during the medication session lasts, we're still trying to figure this out, but days, weeks, possibly even a couple of months. And so as that's been explored, there's a lot of opportunities for patients to really truly rewire parts of their brain. We're seeing now in neuroscience actually form new synaptic connections that didn't exist before, all within that process that primarily follows after the medication session. And so it's really incredibly important for the therapist in that environment to help assimilate a patient's insights. The reality is they will have thoughts when they're in the shower, when they're driving to work, when they're at dinner, about things that they experienced during their medication session that they're then going to want to bring into the therapeutic context during the integration process. And so it's really important to be ready, to hear it when it comes up. It's not on a schedule, so it might end up being right away. It might end up taking some time. But I think as you get into your own practice, you'll see that there's a lot of rich opportunities to come up. And people say everything from, this is years of CBT in a single dosing session, et cetera. I think from my own personal experience, I was a subject in a ketamine trial at Yale 5 years ago from complex PTSD. That was absolutely the case. It's going to be widely variable depending on people's own personal experience. But I think generally we're seeing that it ends up being an accelerant to therapeutic insight that's really important. So I just want to, a couple of things to realize that, this is really about helping the patient process their experience. Again, in the research protocols, it's typically 3 sessions. But again, we'd love to see it woven into people's general therapeutic experience. So maybe somebody is going to a psychiatrist that also provides psychotherapy, and then they end up going to maybe a dedicated place for the medication session, or it ends up being within that same practice. I think we'll see both happen. And I think everyone agrees that if it can be more connected to all aspects of people's wellness and mental health, it'll be better. So next slide. So one other thing that's a bit of a misnomer for this presentation itself, but we want to mention, is BrainFutures is spending a lot of time right now thinking about how do we ultimately get therapists and the drug developers reimbursed for access to these medicines. The reality is this is human capital intensive. Preparation and integration, sitting with someone 6 to 8 hours. This is new territory, for a new class of drugs. And most of the protocols, if you kind of cost them out, it'll be $10,000 or more. And so we're going to need insurance reimbursement to make that happen. And so one of the things that we've been doing is really anticipating all of the roadblocks and areas that we need to prepare for to allow, frankly, you to be able to practice in the next couple of years. And we've been active in that, including just recently, the American Medical Association has adopted a new long-acting code specifically to mirror what happens during an MDMA or psilocybin-assisted therapy session. We'll have a coding and reimbursement guide coming out later this year for therapists that are interested in how to prepare to incorporate this into their practice. But we think it's really important to make you aware of, because when you have a new class of drugs and a new approach to it, you really got to show use within the field. And so if you are curious about this and you want to be involved, please reach out to us at BrainFutures, because we would like to talk to you about how to start to do this early, so that you can help make the case for why this is something that should be more permanently adopted by payers and, frankly, the American Medical Association, which manages the CPT process. So with that, I'm going to pass this back over to Victor.
Thank you, David. So on the topic of the cost of these services, one conversation that's very complex and that we won't be able to cover in all of its aspects today is around access and inclusion. And so these conversations are both concerned with how our historically marginalized communities going to access these therapies, and also how our clinicians of color, or clinicians that represent historically marginalized communities, going to have access to training and education. And so if we look at our current mental health system, we recognize that there are already barriers that keep Black, Indigenous people of color from accessing adequate care due to lack of access to affordable care, racism, discrimination, lack of access to culturally competent care, historical trauma and cultural dislocation. So the field of psychedelic-assisted therapy is not exempt from these same issues, and it's being developed and built out and structured within the systems that already exist. So these are things that we need to be paying attention to with regard to these new therapies, so that we're not perpetuating some of the issues, or many of the issues that we're seeing with our current mental health system, that really can lead to some of the outcomes that we see, or continue to make them worse in many cases. So again, in psychedelic assisted therapy, we see similar issues arise, and we know from research that the majority of studies have been the research participants have been white. And so when we talk about generalizing results and being able to apply results to different communities, when we have a population or participant pool that's homogeneous, it's difficult to take those results and say that they can apply to really need to be focusing on in our studies, so that those communities are also represented and are adequately cared for in this context. These ethical issues with regard to administering powerful psychoactive substances without a clear understanding about the cultural and historical context. So through research, we can learn ways to approach different communities. We can learn more about the unique needs of those communities and about their unique experiences. But without having those folks being involved in the studies, both as participants and as clinicians, we're missing a lot of data that actually could perpetuate harm. And I talked earlier about racial trauma and how racial trauma also comes from institutionalized racism and from systemic racism. And so if we're not paying attention to these unique needs, we can end up actually re-traumatizing folks that are coming into a clinical study or coming into our office looking for care, and in the process of that experience discrimination or racism, whether it's implicit or explicit. So I today want to offer a framework that I think could be supportive generally for doing this work. And that framework is psychedelic harm reduction and integration. And I want to start by saying that I know the term harm reduction has a lot of different meanings for different folks, depending on the environment that this concept is being applied in. But with regard to psychedelics, it's really a focus on preparing folks to be ready to either head into a clinical study or into a medical context to experience psychedelic assisted therapy, or if they are using, have used, or are planning to use psychedelics out in any context, whether it's medical or outside of a medical environment. The focus is to really use this framework as a trans-theoretical and trans-diagnostic framework to support people in being safe. And so the harm reduction part of this model focuses on making sure that people are educated, people are prepared for whatever decision they're going to make with regard to their engagement with psychedelics. And then the other part of that is also ensuring that they have a space to be able to integrate. And so the model really emphasizes and preparation, safe use of substances, really providing a client with a supportive and non-judgmental therapeutic environment. So that requires us to really look at what are the models that we currently hold about drug use, what are the stigmas that we hold as a healthcare field generally, and really allow the client to be a expert in their own experience and really the driver of their own lives. And our role is really to just be supportive and ensure that the client is safe in that decision making. And lastly, it's the integration piece, which David spoke to earlier. So if you're looking at this model, a lot of it matches up with the screening assessment, with the preparation that you would see, the preparation, and then the integration that you would see in a clinical trial, for example, for psychedelic assisted therapy. But the good thing about this model is that you don't necessarily have to administer medicine to folks to be able to use this framework. So you can use it as if you're a psychedelic trial or potentially offer this to your clients. You can use this model, but also if you're just getting clients in your office that are saying, "Hey, I heard about this ayahuasca retreat in Peru," or "I watched How to Change Your Mind and I want to try psilocybin." You're prepared and educated to support that person in making those decisions and doing it in a way that's safe for them. So just to give you an example of the changes that we're seeing in public consciousness and understanding of these substances, in 2019, there was an estimated 5.5 million people in the United States who use hallucinogens or psychedelics. And since 20, reports of hallucinogen use have increased dramatically among young adults between the ages of 19 and 30 years old. And I do want to mention that although we've seen that increase in young adults, in adolescents, the use has actually decreased. So I know sometimes folks are concerned that that if we embrace these models of care, or if we're shifting the way we think about these different substances, that we're concerned about young people and potential increased use there. But actually, what we've seen is that there's been an increase in that. And lastly, I want to share that there was an anonymous online survey done of about 1,400 people that were using psychedelics. Found that 72.5% of those individuals had never discussed their use or psychedelic use with their primary healthcare provider. And so this points to again, the need for us to be educating and providing a non-judgmental and supportive and inviting environment for our clients so that they can discuss these experiences and we can make sure that they're safe. But it also speaks to the need for us as healthcare professionals to really take time to educate ourselves. We see the uses growing up, and with use going up and clients not talking about their experiences, that's a concern, right? The kind of left the station with regard to psychedelics, and it's going to continue to rise. The use is going to continue to rise. And if people aren't talking about that, then that creates an area of risk for folks to really be harmed and not have a space to process questions that they may have or their experiences. And then lastly, I want to talk a little bit about decolonizing mental health. And uh, David earlier went through the elements of psychedelic-assisted therapy. And if you look into traditional ways of approaching these medicines in indigenous cultures, you'll notice that a lot of the language and a lot of the process that's used with engaging with these medicines in the medical context have actually been, from those traditions. And so I think that generally we're starting to really understand that there's wisdom and that there is value to traditions that may not necessarily come from a Western kind of scientific point of view, and that there's wisdom in other traditions and in other cultures that we could really honor and implement to help heal our communities. And so decolonizing mental health really refers to the process of recognizing that imperialism and colonialism have influenced our healthcare practices and research, and really working towards restoring these practices and really honoring them and creating space for community-based approaches. And that means also respecting the cultural approaches and the unique experiences of our clients that they're bringing into our office when they're talking about their potential interest in these substances, or when they're bringing their experiences and trying to make sense of them. And so in psychedelic therapy, again, it's acknowledging the origin of these medicines, the origin of the traditions and the wisdom, and the origin of the practices, and in the medical model. So how do we begin to do this? So leading with cultural humility, understanding that we're never going to quite know anyone's full experience, and so we need to let that person, as a client or that the community, really teach us what they need and how they can be supported in their process. Centering and incorporating Black, Indigenous, people of color, and their perspectives in our work to ensure that they're included. Again, when we look at the studies, the majority of studies have been homogenous. And I will say that MAPS has done, from what I've heard in my conversations, MAPS has done a good job in this last study, their phase 3 study with MDMA, of ensuring that study was representative of the U.S. population. And so we are seeing that organizations or the sponsors of these drugs that are trying to get approval are starting to pay more attention to the need for diversity. And then lastly, it's really challenging the dominant paradigms in the field of medicine. So we really need to start challenging some of our old ways of thinking around drug use, around power dynamics in with our clients, and who's really the expert in the room when it comes to the client's experience, and all of these different ways. I think psychedelic-assisted therapy offers us what's going to be a beautiful but also challenging moment for us to really shift the way that we've done healthcare and shift the way in which we've supported communities in healing. And although it's challenging to let go of some of the ways that we've approached in the past, I think that embracing these new medicines and embracing these new approaches could really help us make a giant leap in mental health. So with that, I'll hand it back over to David to talk a little bit more about what you can do now.
Great. So thank you. So I think the number one thing we would recommend, if you're at all curious, is just educate yourself. There's now a new psychedelic medicine journal that just published for the first time a couple of months ago, but you're going to go into Nature and JAMA and many other well-respected, the New England Journal of Medicine, these journals, and see a lot of articles on these different topics. I just recommend, if you're in sort of wired for that level of detail to start there. But if you also just want sort of a nice overview, I definitely would recommend Michael Pollan's book of How to Change Your Mind. If you want an even easier digestible form of it, there's a 4-part Netflix series called How to Change Your Mind as well. It looks at 4 of the compounds, including MDMA and psilocybin, and that might be helpful too. And then additionally, you could get training. I mean, the reality is Fluence does a really great job of looking at how clinicians can access this work. But then also from a harm reduction standpoint, there are ways to start to get involved with efforts right now. For instance, the University of Michigan is passing out test strips for people to start to think about what their access looks like, because obviously college students are experiencing this. We want to make sure that particularly with fentanyl, being a major risk on college campuses, there's activities there. So if you're publicly health oriented, I think that's a great way to participate. If you want to sort of experience what's happening right now, the Fireside Project is a new-ish, I think it's 2 years old now, nonprofit focused on calls. It's a call line for people that are either actively within a psychedelic experience or integrating their experience. For legal reasons, they do not do preparation because these are illegal activities still. But they're actually training a lot of people that are primarily now licensed practitioners about how to handle calls and handle situations with people that are actively involved. And so I definitely recommend them as an organization that you can sign up and be trained by them on how to monitor folks today. So I think that would be really helpful. Additionally, you can support clinical trials. The reality is there, as you saw on that map earlier, happening all over the world. And that's just the US map that I've shown. But the reality is that if you do want to get trained, you do want to participate in this, you want to understand this modality, whether or not you're a licensed practitioner or you're a technician that can help, these labs are popping up fairly frequently right now, and they're going to need human capital, particularly therapists that are going to be able to sit during these sessions. And so I would reach out to your local institution. You can go onto clinicaltrials.gov and see if they're already active. And if so, get involved there. I think that would be helpful too. And then I just say, from an advocacy standpoint, there is a lot going on. It's a little trickier than this in this space than in a lot of other classes of compounds, because there are different ways in which people are trying to make this accessible. We're talking specifically today about the medical and behavioral health model, but there are also wellness models and decriminalization efforts around the country that are happening too. Depending on how you're wired or how you're interested in that, psychedelic alpha is a pretty helpful, independent view of what's happening in the space. And they're tracking what is now nearly 30 states that have active legislation right now at some aspect of psychedelic access. Frankly, there's not a lot on the medical access yet, but we anticipate that'll probably change in the next couple of years. But there's additionally efforts happening. NIH is starting to fund research in this space. We're starting to hear Health and Human Services have an interest as well. You might have saw several months ago that SAMHSA was starting a working group to think about how to incorporate this into their activities. And so I think it's just, if you're interested in the advocacy side, there's a lot to get involved in. And the two groups that I think we would mention is Reason for Hope. It's actually led by a 3-star general from the Marine Corps that is really trying to figure out how to make this available to primarily veterans and first responders. The reality is the subgroup of folks most active in trying to heal through psychedelic-assisted therapy are special operators. So you're seeing a very active community among former Navy SEALs, Green Berets, Army Rangers, where they are coming back from service and not feeling like they're adequately put back together after the experiences that they've had. And unfortunately, they have to go to Peru and Mexico to get access to these compounds right now. So there's a really robust community doing that today. And so General Steele, the 3-star general, is working through Reason for Hope to try to bring that stateside. And how do we allow our warriors, particularly from a special operations community, to be able to reintegrate into society after their experiences abroad in a healthy way. And if you know anything, the 22 service members a day commit suicide, alcohol use disorder, and depression are wildly challenging topics for that community. And so I think Reason for Hope is a great way to start to get involved both on the advocacy side and then really start to understand the stories of how this is working. And then Psychedelic Medicine Coalition is relatively new, but they're advocating for access to the medical model specifically of psychedelic-assisted therapy. So those are all ways that you can start to get active, and you'll find that no matter where you live in the U.S., you'll find a local community that is thinking about this. Additionally, if you're abroad, it's very common as well, particularly in Canada and Europe, for similar conversations to happen as well. So if you have any questions or insights, we'll give our information at the end. You can reach out to us and we can help you find the right way to get involved. And then the next slide, I just would say like resources for further learning, like this is Fluence's site, fluencetraining.com. Please look at what they have going on and see if it's a good fit for you. BrainFutures, if you look at our psychedelic-assisted therapy sub-tab, you're going to find our paper series as, again, on the research on how we're going to make it clinically accessible and a much more robust review of what those elements are that we talked about previously. So if you want to start to go through that as well, learn more, great. You'll be able to find our contact information on those sites as well. Here's the information for Fireside as well, firesideproject.org. They actually have an app that if you do have clients that are thinking about having this experience and might need support while they're actively involved, it's something to think about, just making people aware of if it's appropriate. And then finally, on the bottom, you'll see clinicaltrials.gov. And so you can get a sense of where all the research is happening right now, what indications they're looking at. We talked about depression and PTSD, but we're also seeing out of UCSD right now, the University of California, San Diego, a study around phantom limb syndrome and pain management. And we're starting to see a lot of other indications that are being explored. And so it's a really exciting time if you want to track the research as well. So I think on the next slide has our email addresses. We really appreciate you taking this time to hear about psychedelic-assisted therapy and how it's going to come into the U.S. medical system in the next year and a half and so. And you can see on the left side there, Victor's and my email addresses. So, please, if you want to reach out for anything, that's the best way to reach us. And then also you'll see where to learn more from the Mental Health America. So we really appreciate this time, and I'll let Victor have the last word, but thank you so much for joining us today.
Yeah, thank you all so much. And David said, if you have any questions regarding anything that you heard today, please feel free to reach. Thank you so much for tuning in.